Doctors, what is the most disturbing case you have treated? When I volunteered as a nursing assistant at the local hospital, on my first day, I was asked if I'd like to help bathe an elderly patient. I was told he was nearly comatose, riddled with cancer, and at death's door. I agreed, but nothing could have prepared me for the sight of him. His pallid skin was stretched tightly over his bones, and his eyes were dull and vacant. Most of his skin was mottled purple where his blood vessels had ruptured. He couldn't speak, and he screamed whenever the other nurse and I had to roll him over. He was constantly being injected with morphine to manage the pain. 2 days later, he passed away. That was when I decided the medical profession wasn't for me. Subscribe. As a paramedic, I once responded to a call that came in as traffic accident, baby ejected. We prepared for the worst we could imagine. We arrived about 8 minutes later. A state trooper was already on scene, trying to clear the area of bystanders and gawkers while preserving the scene. He had covered what he thought was the baby with one of the yellow death sheets troopers keep in their trunks. When I lifted the sheet to check for vitals and pronounced death, I realized it wasn't a baby at all. It was the upper half of a 19-year-old girl who had been driving a small pickup truck about 50 yards away. She had been driving while arguing with her husband, also 19, who was in the passenger seat. They were going around 55 miles per hour on a 2-lane road when they met an oncoming truck hauling a double-wide mobile home. She drove under the front corner of the mobile home, which literally cut her in half. Her lower half stayed in the driver's seat, while her uninjured husband sat beside her, forced to witness everything. The truck then skidded another 50 or 60 yards, sideswiping a minivan and sending it upside down into a ditch. When the pickup finally came to rest, her lower half fell out onto the ground. We also found a trail of ribs leading from the cab to the truck bed and then down the pavement to where her upper half was. It looked like something out of a movie set. Her upper and lower halves looked almost untouched, but from mid-chest to pelvis, everything was scattered along the road. The husband was completely hysterical, babbling, swinging at people, totally incoherent. A witness who lived right in front of the crash site began having chest pains and had to be transported as well. We took the husband, and I called medical control. I actually received permission to administer 4 Valium, something paramedics are normally only allowed to give for grand mal seizures. The driver of the big truck was physically fine but deeply shaken by what he had seen. That was 16 years ago, and I can still remember pulling up to that scene like it was yesterday. Subscribe. I work as an autopsy technician and death investigator. We once had a morbidly obese man who died in a cheap motel room with the heat cranked all the way up. He wasn't found for several days. By the time we got him to the morgue, he was horribly bloated from decomposition gases and covered in purple and green blotches. There was a lot of skin slippage, just touching him made layers slide right off. Our forensic pathologist started the initial Y incision, and the force of the escaping gas blew gore all over us and the ceiling, making a sound like a wet balloon being squeezed. We all froze for a second as the worst stench I have ever smelled filled the room, like something that had crawled straight out of Satan's ass. Then we just started laughing, because honestly, that's all we could do at that point. It didn't help that he was leaking liquefied fat all over the floor. That stuff is unbelievably slippery. My boots have never been the same since. During my EMT class, training course to become an emergency medical technician, one of the instructors told us about a call she had responded to on the freeway. There were 2 cars involved, and one of them carried an elderly couple. Because she was small, she often got assigned to crawl through car windows to reach and stabilize patients while the rest of the crew worked on prying open the doors. In this case, she climbed into the back seat of the elderly couple's car and began to hold manual C-spine on the woman, keeping her head still to prevent further spinal injury. As she held the woman's head, it came off in her hands. The woman had been decapitated in the crash, and no one had realized it yet. My instructor said she had to take a couple of weeks off afterward and went to therapy to process what happened. I can't imagine what it must have been like to go through something like that. I'm an ERRN, that's an emergency room registered nurse. So far, this is the only death I've experienced on the job that has truly cost me nights of sleep. A 24-year-old man walked into the emergency room with complaints of flu-like symptoms that had lasted about 3 days. He said he came in the day because he'd started developing a rash all over his body, and he didn't know what it was. Tragically, that rash was actually the result of bacterial meningitis, a severe infection that was causing him to bleed both internally and externally. By the time we got him into a treatment bay, he began crying blood. The terror in his eyes was unmistakable. He deteriorated fast. His lucidity faded along with his blood pressure, and the last thing he said, right before his heart went into pulseless VTAC, short for ventricular tachycardia, a deadly heart rhythm, was something about his mother. We couldn't make out the words. I watched the light fade from his eyes as we started compressions, chest compressions for CPR. The code, that's what we call a full cardiac arrest resuscitation, lasted close to an hour. At first, we managed to keep his oxygen levels up with a ventilator, defibrillation shocks, and emergency medications, but the bleeding was too much. His airways filled with blood faster than we could suction it out. No amount of fluids or drugs could maintain his blood pressure. He died soaked in his own blood, nearly unrecognizable, his skin turned almost entirely purple and his face swollen. Later, we found out more about him. He was a neurobiology student, an athlete, and he lived a healthy life. He had a loving girlfriend, practically his fiancée, a big family, and lots of friends. He had beautiful curly hair. That made his death hit harder, not just because of how young he was, but because everything about him spoke of potential and life. The unanswered pleas to God from his family echoing through the room only made the loss feel heavier. When it was over, I helped drag his body and zip him into a body bag. I was working a trauma block, a shift dedicated to emergency trauma cases, when we heard over the radio, 40-year-old traumatic arrest, knife wound. ETA 2 minutes. It was already after a 30-hour call shift, but I wanted the experience of placing a chest tube, so I stayed, figured this might be my chance. We had misheard the radio. EMS, Emergency Medical Services, arrived not with a 40-year-old, but with a coding 4-year-old, a child in full cardiac arrest, whose throat had been slashed open by her own mother. The firefighters told us that when they arrived on scene, the mother was still holding the knife and kept repeating, "I'm sorry." Inside the trauma bay, we were struggling to establish an airway, trying to ventilate the child while our attending physician led the code, the resuscitation effort. 5 minutes in, we realized the neck vasculature, the arteries and veins, had been completely exposed and severed. There was no blood flow at all during chest compressions. She had already lost most of her blood before EMS even got her to us. My dad has been a nurse for nearly 20 years. Over the years, he's worked in the ER, emergency room, radiology, and now in the ICU, intensive care unit. He's one of the most respected nurses in the hospital, I would know, because I used to work there too as a phlebotomist, someone who draws blood. Anyway, our hospital is labeled a bariatric center of excellence, which basically means we treat a lot of patients who are severely overweight. One day, I went up to the 4th floor, the neuro unit, to do a blood draw. As soon as the elevator doors opened, I was hit with the smell of feces, a thick, rotten egg kind of stench that hung in the air. I didn't think too much of it at the time. The hospital is old and poorly ventilated. But later that evening, when I got home, I asked my dad about it, since the ICU is on the same floor. He sighed and told me what had happened. They had a patient who weighed around 550 pounds and had been admitted for severe abdominal pain. It turned out he hadn't had a BM, bowel movement, in almost a month. Before being transferred to our ICU, other clinics had tried giving him multiple enemas, but nothing worked. So my dad said he was inserting one of those rectal balloon catheters, a device that goes into the rectum so a collection bag can be attached. He turned around for a moment to check the patient's monitor, and then he heard a strange dripping sound behind him. When he turned back, there was, in his words, a river of shit pouring off the bed. The floor was completely covered in a month's worth of feces, dripping, splashing, and spreading everywhere, including all over my poor dad. He said the nurses had to roll up their scrub pants like they were going clamming, and it took them over an hour to get everything cleaned up. Housekeeping came by, took one look, dropped off their cleaning cart, and said, "Nope," before leaving. And right after they finally finished cleaning, it happened again. I can't even imagine the smell in that room if it was enough to stink up the entire 4th floor. After hearing that story, I don't think I've ever had more respect for nurses, especially the ones who work in critical care. I have two stories. I'm a medical student. 1. The bread incident. A super obese woman, yes, that's an actual medical term, came to clinic complaining of a foul odor she'd been noticing. And yeah, me and the attending noticed it too. It smelled like something between rancid milk, rotting fish, and a disemboweled skunk swimming in garbage. We did the usual workup, took a detailed medical history, performed as thorough a physical exam as possible, which wasn't easy, given how many folds of fat and skin she had, including a rectal and genital exam just in case there was something unusual down there. We also ordered some basic lab tests. While the attending and I were discussing how we had absolutely no clue what was causing the smell, the nurse came out holding a green, soggy lump in her gloved hands, and waved it right in front of our faces. I nearly threw up on the spot. Turns out, the woman had been using pieces of bread to soak up sweat by tucking them between her skin folds. Apparently, she forgot about one of them, and it stayed there for weeks, slowly marinating in her body heat and moisture. I got sent back in to check if there were any other hidden pieces. Thankfully, there weren't. But having to lift and inspect every skin fold was easily one of the most disgusting, and most awkward, moments of my medical training. 2. The exploding thumb. A man came into the emergency department, after getting drunk and fighting with his girlfriend. In a brilliant act of drunken logic, he decided to light up some M80s, powerful fireworks, and throw them at her. Unfortunately for him, he waited too long to toss one and ended up blowing off his own hand. He was brought in completely wasted and bleeding heavily. We stabilized him and took him to the operating room. While the hand surgeons were cleaning the remains of his hand, the surgery resident and I were busy repairing the lacerations across his chest. One of the hand surgeons said, "Wow, this is a mess. Did anyone at the scene find his thumb?" No one knew. We kept working, cleaning, and suturing wounds, and then, buried deep in a gash in his upper abdomen, we found it, 2/3 of his thumb, lodged inside him. If he hadn't been so overweight, it probably would have gone right through into his peritoneal cavity, the space that houses your abdominal organs. I interned in a city that gets brutally cold in the winter. During that time, many homeless people who were struggling to survive outdoors would come to the emergency department, just to get admitted for a night. It wasn't uncommon. They'd get a warm bed, a few hot meals, and a chance to clean up. One fellow who came in was in especially rough shape, said he couldn't walk. The nurses, bless them, did most of the cleanup, delousing, sponge bathing, dressing the open sores. My job was to do the full physical exam, including the mandatory rectal exam. So there I was, literally having to lift this scrawny flap of a butt cheek and scrape away the encrusted dirt, feces, and matted hair just to even find the rectum. The moment I got it exposed, I turned about 180 degrees and dry heaved straight into the sink. Before this poor guy could be discharged, though, he needed a podiatry consult, a foot specialist. His feet were black and gnarled, with thick yellow toenails. The big toenails had grown in a complete circle and were actually piercing into the bottoms of his toes, which explained why he couldn't walk. The podiatry intern came in, started soaking the guy's feet, and then pulled out what could only be described as modified tin snips to tackle those nails. Now, you know how some people unconsciously open their mouth when they're concentrating really hard? Yeah. That. He clipped one of those nasty nails, and it flipped right into his mouth. We both shared the same sink that day. This is a story from one of my friends who worked as a paramedic in Hamburg for a while, and fair warning, it's disgusting. They were called to check on an unconscious person, someone addicted to so-called magical substances, who was slumped over on a park bench near the train station, where most substance users used to hang around back in the day. They approached the man and tried to wake him up, checked his vital signs, and then carefully laid him on the ground. He wasn't wearing shoes, only plastic bags wrapped around his legs. If you've ever been around people heavily addicted to magical substances, you know that hygiene often becomes the last thing they care about. Over time, this neglect can become even more dangerous than the addiction itself. Untreated wounds, infections, and scabs that never heal. This guy smelled absolutely horrible, and once they started to check his plastic bag shoes, They immediately saw why. His legs, up to his knees, were completely black and crawling with maggots. He had severe infections in both legs from repeatedly injecting into his veins and never treating the wounds, much like those viral photos of homeless people you sometimes see online. I'm not posting those here for obvious reasons. My friend said that when they lifted the plastic bags, which had partially melted into his decaying flesh, small mounds of maggots spilled out and crawled around his feet. Hands down, one of the most disgusting things he's ever witnessed in his career. Doctor here. When I was working in the emergency room one evening, I had one of the worst experiences of my career so far. I was called to one of the examination rooms designated for infectious patients, which is already a bad sign, because it usually means an abscess that needs to be drained. But this time, it was far worse. The nurse told me we had a man with bilateral venous ulcers on his legs, meaning open, infected wounds on both lower legs caused by poor circulation, and that they were now severely infected. I looked through his medical records and saw that his last doctor's visit had been about 10 months earlier, with no follow-ups from any nurse or general practitioner. So I asked my nurse when someone had last checked his legs. Not since his last entry, she said. Then I asked when he'd last changed his dressings. He hasn't. Some background on the patient. He was an old man living alone in a trailer parked in the middle of the forest. He had no running water. He drank heavily and had a general I don't give a damn attitude. Great. I suited up and went into the room. The smell hit me immediately, a mix of stale beer, mold, and infection. Different infections have distinct odors, and this one was pungent, almost sulfuric. I introduced myself to the patient, who clearly had no idea what was going on. All he wanted, he said, was antibiotics for a flu, and he couldn't understand why anyone wanted to look at his legs. Why the hell do you want to see my legs? They were taken care of last year, he grumbled. Fantastic. We started to unwrap the dressings. The outer layers were crusted and cracked as we peeled them away. Deeper in, the bandages turned a sickly yellow, and the stench grew stronger. One of my nurses had to leave the room to throw up. Then I saw it, small, wriggling, a maggot inside one of the folds. Oh, great. When we finally uncovered the wound, we found dozens of them, at least 50 maggots feasting on the rotting flesh of his leg. The smell was indescribable. I tried to breathe through my mouth, but then it felt like I could taste it, which somehow made it worse. My nurse came back into the room, took one look, and immediately ran back out again. We unwrapped his other leg. Same story, except this one was worse. The infection had eaten deeper, and I could actually see exposed tendons at the base of the ulcer. Delightful. We had to clean off all the maggots, scooping them into a metal bowl. Some escaped, squirming onto the floor and crawling everywhere. I had to watch my feet so I didn't step on them. After that, we hosed the patient down to get rid of some of the smell, then took him to the operating room for debridement, the surgical removal of dead tissue, and a fresh vacuum dressing. He was discharged a few days later with strict instructions and follow-up appointments scheduled for dressing changes and checkups. We never saw him again. I work as a paramedic in Canada, more specifically, in Ontario, and one day we were dispatched to a call requested by police. The radio call came through as code 4, emergency, and code 5, obviously deceased, with an unusual request: bring a box of N95 masks. My partner and I were confused but followed the instructions. When we arrived on scene, a police officer met us outside. As soon as I handed him the box of masks, he looked visibly relieved. My partner asked what was going on, and the officer simply pointed us toward the door. We didn't even make it 2 steps before the smell hit us, that unmistakable, gut-turning smell of death that's had time to fester. At that moment, the request for masks made perfect sense. When we poked our heads inside, we were greeted by what used to be a person, a woman, judging by what remained. The officer explained that she hadn't been seen or heard from in about 2 weeks. When someone finally came to check on her, they found her melted, essentially. He told us that when she was alive, she probably weighed around 400 pounds, about 180 kilograms. But after 2 weeks in that environment, her body had broken down. What we were looking at was more of a puddle than a person. To make things worse, her heat had been left on high, even though it was the middle of summer, around 30 degrees Celsius, or about 85 degrees Fahrenheit. The blinds were wide open, and she had been sitting in direct sunlight the entire time. It was, without exaggeration, one of the most disgusting and unforgettable sights I've ever seen in my career. I'm a surgical registrar, that's a surgical resident, for those outside Australia, and this happened while I was working in a small rural hospital in Australia. One morning, the medical team asked us to review a patient who had been admitted overnight through the emergency department. The CT scan, computed tomography, showed what appeared to be a very distended bladder. Apparently, the staff in the emergency department had tried to insert a catheter but had some difficulty, so they called me to take a look. I went up to the ward, reluctantly, I might add, and managed to get the IDC, indwelling catheter, in, though it took quite a bit of effort. The poor woman was also fecally incontinent, which didn't make things any easier. A small amount of urine drained out, but something about the situation just didn't feel right. I went back to review the CT scan more carefully. The catheter that had been placed in the emergency department appeared to be positioned correctly, or so it seemed, but just behind the bladder was this enormous uterus, completely distended and filled with fluid. Then I read the radiology report. I swear it said something almost exactly like this: conclusion, there is a very distended bladder. The catheter balloon is situated in the prostatic urethra. Moderate to severe hydronephrosis is noted. Now, if you know anything about anatomy, you'll realize what's wrong here. The patient was a woman. There is no prostate. I called my consultant, and we decided to take her to theater immediately. With great difficulty, we dissected our way around this massive uterus. It was clearly abnormal, swollen and tense, like it was about to burst. We called in the O&G team, obstetrics and gynecology, for assistance, and while working together, the worst happened. The uterus ruptured. A tidal wave of pus, thick, yellow-green, sulfur-smelling sludge, came pouring out. The smell was indescribable. People were gagging all around us. The scrub nurse threw up into her mask. The consultant turned to me with a look that said, "This is your fault for bringing this case to theater." We finally finished the surgery and got the uterus removed, and I was beyond relieved to be done. When I got home that night, I could still smell it. I showered for an hour. Still smelled it. Went to bed. Still smelled it. Woke up the next morning, couldn't even eat breakfast because the stench lingered in my mind. When I arrived back at the hospital, I noticed everyone was wearing masks. Turns out the smell had been so strong, and the theater's ventilation system so outdated, that it had pumped the stench through the air vents. All night, tiny amounts of that foul, sulfuric air had been circulating through the entire hospital. The smell of that infected uterus haunted the building, and me, for days. I'm a medical student, and I've seen some pretty nasty things myself, but the best stories I know come from my parents, who are both doctors. Story 1, Mum's patient. Early in my mum's training, an elderly man came into the emergency department. On examination, his feet were severely gangrenous, black, shriveled, and reeking. My mum began managing his various issues and decided that soaking his feet before dressing the wounds would be the best approach. So she filled a basin with warm water and left his feet to soak while she went off to deal with other tasks, as junior doctors often have to. When she came back about half an hour later, she found 10 little piggies floating in the basin. The man's toes have completely detached during the soak and were just bobbing around in the water like something out of a horror movie. Story 2, Dad's patient. My dad's story took place while we were living in Scotland in the early 1990s. It was a rare sunny day, the kind of day when people start believing they might actually get a tan. Now, the Scots, especially the fair-skinned Celtic type, are not exactly known for their tanning abilities, think wiry red hair and milk-white skin. But one particularly optimistic man decided he was going to give it his best shot. He laid out several sheets of tin foil to reflect the sunlight and then basted himself in cooking oil like a Thanksgiving turkey. A few hours later, he showed up at the emergency department with third-degree burns all over his body. Apparently, he'd learned the hard way that Scotland's weak sun can still roast you alive if you turn yourself into a human solar oven. I was assisting in a crash C-section, an emergency cesarean section, once. The mother was eclamptic, meaning her blood pressure was dangerously high and she was having seizures. The only cure for eclampsia is to deliver the baby. but she was only 25 weeks pregnant. Everything happened so fast there was no time to administer an epidural, the spinal anesthetic that keeps the mother awake but pain-free, so we had to put her under general anesthesia instead. The baby had a strong, healthy heartbeat, but at 25 weeks, that doesn't guarantee survival. After delivery, the father sat in the recovery area beside his wife's stretcher, holding their dying baby. He didn't say a word, just sat there with tears streaming down his face, staring at the tiny bundle of blankets in his arms. Inside was a perfectly formed little face, struggling to breathe. The mother was still unconscious from the anesthetic, but when I walked in, the father was holding her hand with one arm and cradling the baby with the other. He was humming a lullaby, softly, shakily, as tears ran down his cheeks. He stayed like that for a long time, just rocking the baby gently back and forth, humming to him, crying silently. Eventually, the baby stopped breathing in his arms. The father didn't speak. He just kept rocking him, still humming that same lullaby. This is one of my father's stories, and it's one of my favorites to tell. My dad was on his way to pick up some pizzas from one of our favorite places. He had just turned down the intersection leading toward the restaurant when he heard an extremely loud crash. He turned around just in time to see a motorcycle helmet flying through the air, about 30 feet up. A motorcyclist had run a red light and slammed directly into the side of an SUV carrying two teenage girls, both dressed up for prom. The guy had been driving far too fast, especially considering you can't even see that intersection until you're almost right on top of it. When he hit the SUV, his face struck the bottom edge of the rear driver's side window. The impact launched his helmet straight into the air, shattered the window, and left a massive dent in the door. The inside of the car, and the poor girls in their white prom dresses, were sprayed with specks of blood. My dad pulled over in a nearby parking lot and ran toward the wreck. A few people had already gotten out of their cars, but they were standing in shock, unsure of what to do. The man was lying in the middle of the intersection, bleeding heavily from his mouth. He had taken nearly all of the force of the crash directly to his face and jaw. He was still alive, but barely breathing. My dad rushed over and tried to clear his airway. He used his fingers to scoop blood out of the man's mouth so he could breathe, then pulled his tongue and jaw downward to open the airway. Later, he described the man's chin as having no structure at all, the bones completely pulverized. He said it felt like a handful of mush. My dad held the man's neck steady and kept his airway open until the ambulance arrived, which took about 10 minutes. Had my dad not been there, that man would have died before help arrived. When paramedics finally got to the scene, my dad introduced himself, told them he was an anesthesiologist, and gave them a quick summary of what he'd done and what he'd observed. Once the man was taken away, my dad realized he was covered in blood. He walked the short distance to the pizza place, his forearm stained red, and asked someone to open the door for him. He said people just stared, horrified, as he calmly walked to the restroom to wash up. After cleaning himself, he grabbed the pizzas and drove home like nothing had happened. The man later turned out to have multiple broken vertebrae, an almost completely destroyed jaw, several facial fractures, a broken collarbone, broken ribs, and a collapsed lung, among other injuries. My dad, having worked in hospitals for nearly 20 years, most of that time in busy emergency departments, didn't think much of it at the time. To him, it was just another day, only outside his usual environment. He didn't even mention it to us until 2 days later. But here's the part that always gets me. Exactly 1 year to the day after the accident, my dad was at work when he got a page asking him to come down to the hospital lobby. When he arrived, he saw a man standing there who looked vaguely familiar. Before he could say anything, the man walked straight up to him, threw his arms around him, and started crying. My dad immediately realized who it was, the motorcyclist. He started crying too. Through the tears, the man kept repeating, "Thank you. You saved my life." They talked for a while about his recovery and physical therapy. My dad doesn't think they ever kept in touch afterward, but he said it was one of the most meaningful experiences of his entire career. I'm an intensive care unit, ICU, doctor at a major trauma center, with years of emergency room, ER, experience. Let's see. A group of intoxicated teenagers was driving around town. One passenger in the back leaned out the window, his upper body hanging outside while his friends held onto his belt. The drunk driver thought it would be funny to scare him by swerving close to a street sign. Moments later, people burst through the ER doors screaming. I rushed outside, they grabbed my coat and dragged me to the car, where a headless body hung halfway out the window, missing most of both arms. One of the bystanders, completely hysterical, tried to hand me the head, yelling, "Do something." Another case, a young woman had been drinking at a bar and decided to ride her motorcycle home without her helmet. She turned the wrong way down a one-way street, crashed into a car, and was thrown headfirst into a street pole. She suffered a massive brain injury that caused severe swelling, the kind that usually leads to death. But in a grim twist of luck, a skull base fracture allowed the pressure inside her head to escape through her nasal passages. For days, large amounts of brain tissue leaked from her nose, and the nurses carefully cleaned her face so her family wouldn't have to see it. She survived, but with significant permanent disabilities. Then there was a man who collided with another motorcycle. He nearly lost his leg, but we managed to save it using a metal rod inside his femur to stabilize the bone. The day after we moved him out of the ICU, he became agitated and left the hospital against medical advice. A week later, he returned with his leg swollen, red, and draining large amounts of green pus from the surgical site. This time, we couldn't save it, he lost the leg, but lived. And finally, one of the most unsettling cases I've seen. A man attempted to pierce his lower area at home, multiple times, using makeshift tools. He developed a severe infection that spread rapidly, filling the tissue with pus. By the time he was admitted, the infection had advanced into his abdomen and surrounding muscle layers, causing necrotizing fasciitis, a type of flesh-eating infection. The smell was indescribable. Despite multiple surgeries to remove the infected tissue, including parts of his lower organs and surrounding structures, it was too late. The infection claimed his life. My father was a plastic surgeon working in the emergency room of a major southern city, so over the years he accumulated more stories than anyone would ever want to hear. But one in particular has always stayed with him, and with me. A family of 4 was driving along an urban highway that ran right past the hospital. The parents were seated in front, and their 2 young children, a boy and a girl, about 3 and 5 years old, were in the back seat. Unfortunately, neither child was restrained with seat belts or car seats. Coming from the opposite direction was a woman driving erratically. Later, it was determined that she was in the middle of a severe psychotic episode. As the 2 cars approached each other, she lost control, swerved into the median, and struck a barrier that launched her car into the air, upside down. Her vehicle came down directly on top of the family's car, crushing the rear portion of the roof. The impact twisted the metal backward in such a way that the parents in the front seats survived without injury, but the back of the car collapsed completely. The accident happened just outside the hospital. In a state of shock and disbelief, the parents pulled their children from the wreck and carried them straight into the emergency room, hoping against hope that something could be done, but it was immediately clear to everyone in the trauma bay that the injuries were not survivable. There was nothing anyone could do. I was working at an urgent care clinic in South Atlanta, Georgia, when a man came in complaining of persistent itchiness on his chest and back. I examined him, took a small skin scraping, and diagnosed him with tinea, a common fungal infection. As I was discussing treatment options, he casually mentioned that he had been experiencing some itching in his lower area as well. After consulting with a supervising physician, we decided that I should perform an examination. I gave him a gown and asked him to change. When I returned to the room, I found him sitting on the exam table wearing only a pair of mesh disposable undergarments, the kind usually given to patients after certain procedures, stuffed with gauze. Curious, I asked why he was wearing that type of undergarment. He explained that he and 4 of his friends, all in their 50s, had undergone a surgical procedure about a week earlier. The skin on the inside of his thighs showed visible irritation, similar to a severe rash, so I told him we'd need to examine the area more closely. When the gauze was removed, I could see that the surgical site was swollen and inflamed, with stitches barely holding together an incision that had partially reopened. There was significant discharge coming from the wound, and a fungal infection had spread throughout the surrounding skin. Despite the obvious infection, The patient seemed unconcerned about the surgery itself, he just wanted the itching to stop. We started him on antifungal and antibiotic treatments and attempted to reach the surgeon who had performed the operation. After several hours of observation, the patient decided to leave on his own, promising that he would follow up with his surgeon the next day. I work in the emergency department under the internal medicine service. In our hospital, it's standard protocol to transfer patients between departments depending on their needs. For example, a trauma patient might be transferred from general surgery to orthopedics if the injuries are localized to the limbs. One day, we were told that a patient was being transferred to our care from the surgical service. All we knew was that his hemoglobin was dangerously low and needed to be stabilized by our team before he could undergo tumor debridement, surgical removal of dead or infected tissue. My partner was assigned to interview the patient before the official transfer, but he wouldn't stop pestering me to go with him. He warned me, "Just prepare your nose. The smell is bad." He was picked up by a good Samaritan off the street. I'd been a nurse before medical school, so I thought I'd handled every kind of smell imaginable: infections, wounds, gangrene. Nothing could surprise me anymore. I was wrong. As we started walking toward the patient's room, the odor hit us long before we even got inside. It was a heavy mix of urine, unwashed body, and something unmistakable: the sweet, rotting smell of a diabetic wound. If you've ever encountered it, you never forget it. The patient was lying on his side. He had amputated legs, both just stumps now, and was missing several fingers. No obvious diabetic foot wounds, though. I noticed a large piece of gauze covering the back of his head and figured that must be where the smell was coming from. I decided not to investigate just yet. He wasn't well groomed, his hair matted, his clothes dirty. We approached from the front so as not to startle him. My partner began asking the usual questions, and the man answered a few, though most of the time he just stared off into space with this blank, distant look. I kept my distance. Something about that stare made me nervous. I half expected him to start screaming or lashing out at any moment. While my partner kept him distracted with questions, I decided it was a good time to take a closer look at his wound. I walked around the bed to get a better view. From a distance, I assumed it was just a large, open tumor. But when I got closer, my stomach dropped. The entire back of his head looked eaten away. Large sections of tissue and bone were missing, leaving what looked like a hollowed-out space where part of his skull should have been. And swarming across the edges of the wound were maggots, hundreds of them, moving in and out of the tissue. The whole area was alive and shifting, and I couldn't look away even though every instinct told me to. That sight, the way the wound seemed to crawl on its own, has stayed with me ever since. The moment I realized what I was looking at, I stepped back, turned around, and walked straight out of the room. Operating room nurse here. This one's kind of long. I was on call one night and woke up at 2 in the morning for a general surgery case. Pretty vague, but at the time, I lived in a town full of young military guys and meth users, so late-night emergencies were nothing new. When I got to the hospital, I was given more details: pararectal abscess. For the uninitiated, that means somewhere in the immediate vicinity of the asshole, there's a pocket of pus that needs draining. Needless to say, our entire crew was less than thrilled. I went down to the emergency room to transport the patient. The ER nurse handed me the chart and said only, "Have fun with this one." Among healthcare workers, vague statements like that are a bad omen. My patient was a 314-pound Native American woman who barely fit on the stretcher. She was rolling frantically from side to side, moaning in pain, pulling at her clothes, and muttering Hail Marys. It took me several minutes just to get her name. Once I confirmed her identity and the procedure, I figured the best thing to do was to get her to the anesthesiologist so we could knock her out and get this circus started. She kept up the theatrics all the way to the OR, nearly falling off the table as we tried to put her under anesthesia. We see patients like this a lot: chronic drug users with sky-high pain tolerance and poor coping skills. Now, it's important to note that tonight's team wasn't inexperienced. I'd already been in healthcare for several years, mostly psych and medical units. I'd seen an 88-year-old man rip a 1-inch catheter balloon out of his penis while screaming, "You'll never make me talk." I'd been attacked by an HIV-positive neo-Nazi. I'd seen some things. The other nurse had over 10 years of trauma or experience. The anesthesiologist had trained at a level 1 trauma center, or as we call them, knife and gun clubs. The surgeon was ex-army, a man of few words and even fewer expressions. None of us expected what came next. We got her under, positioned her in stirrups, and I began cleaning the rectal area. It was red, inflamed, and oozing a little pus, nothing out of the ordinary. Her chart noted 4 drug use through the perineum, so we figured it was just an abscess from dirty needles. Painful, sure, but not catastrophic. The surgeon stepped up with his scalpel, sank just the tip in, and at that exact moment, the patient twitched. That's when all hell broke loose. Unbeknownst to us, the infection had tunneled nearly a foot into her abdomen, forming a massive cavern of pus, rotten tissue, and fecal matter that had seeped outside her colon. The moment the blade broke the surface, that ungodly mixture erupted like a geyser. It blasted out of her like a fire hose. We're talking full-on Jane Austen's Mafia. Funeral scene levels of chaos. We were wearing full waterproof gowns, gloves, face shields, all of it, and it didn't help one damn bit. The bed was in the middle of the room, 7 feet from the nearest wall, and by the end, I was still finding bits of rotten flesh plastered to the far wall. As the surgeon kept cutting, the torrent didn't stop. Each time the ventilator made her diaphragm contract, another surge of gray-brown sludge shot out across the room. Within minutes, the stuff was seeping into the other nurse's shoes. I stood there, 12 feet away, jaw hanging open behind my mask, while the other nurse dry heaved and the surgeon stood on tiptoe trying to keep his socks dry. Then the smell hit. Oh God, I just threw up in my mask. The other nurse choked out before tearing off her PPE and sprinting from the room. It hit me next. My lungs locked up, I couldn't breathe. The stench was pure despair made physical. The anesthesiologist went down soon after, this 6'2" former NCAA tailback stumbling toward the door, gasping for air, throwing it open to the hallway where the other nurse was still puking into a sink. Another geyser burst out, splattering the surgeon head to toe. The only thing in my head was that David after Dentist line, is this real life? Everywhere in the world, no matter where you are, has one sacred thing in common, a bottle of peppermint oil concentrate. Everyone knows where it is, everyone knows what it's for, and everyone prays they never have to use it. You rub it inside your mask to drown out smells like this long enough to finish the job. I sprinted to Central Supply, ripped open the drawer, and found an empty box. Someone had used the last damn bottle and never replaced it. To this day, if I find out who it was, I'll personally shove their head up every meth user's colon in the county. Desperate, I grabbed a vial of Mastisol, a bandage adhesive with a strong smell. Not ideal, but better than dying of olfactory trauma. I rubbed it all over the inside of my mask and handed it to the anesthesiologist, who did the same. Fun fact, huffing Mastisol gives you a mild high. In hindsight, that's probably what got us through. By now, the smell had spread 40 feet down the hallway to the front desk. The nurse out there looked like she'd aged 10 years. Our OR suite looked like the underground river of ooze from Ghostbusters 2, but filthier. When I stepped back in, the surgeon was still going, ankle deep in a swamp of pus, tissue, and filth. He looked like a man performing surgery in the Dagobah swamps, minus Yoda. We didn't speak for 10 minutes while he scraped out the dead tissue. His gown was soaked in brown and red. His eyes watered from the vapors. I finished my paperwork, helped him pack the wound with gauze, taped her buttocks shut, woke her up, and sent her to recovery. Then came the alcohol showers, scrubbing ourselves raw with 70% isopropyl just to get the smell off. It takes 4 or 5 bottles, but it's the only thing that works. As we left the locker room, the surgeon looked at me and said the only negative sentence I ever heard from him in 2.5 years, that was bad. The next morning, the entire department still reeked. Housekeeping said it took them nearly an hour just to suction up all the fluid and debris. The OR was quarantined for 2 full days to let the smell clear. Now, when I hear new recruits in healthcare brag about the worst thing they've seen, I just laugh. Kid, you haven't seen shit.